Hello everyone, I am Manali Reshamwala, Assistant Professor from LG Institute of Physiotherapy. Today I am going to talk about atrial septal defect. It is one of the congenital heart disease. In short, it is known as ASD. It is a part of syllabus for final year physiotherapy students of Gujarat University, and the subject is physiotherapy in cardiopulmonary conditions. So let's see what is ASD. There is a defect in interatrial septum. Initially, there is left to right shunt due to pressure variation in left and right side of the heart. So, it is a type of acyanotic congenital heart disease. The patient with ASD does not have cyanosis initially. That's why it is known as acyanotic congenital heart disease. Here in a figure, we can see there is an opening in the interatrial septum. So that because of pressure changes, as left side of the heart is having higher pressure than the right side of the heart, so shunt will be from left side to the right side. So oxygenated blood will be mixed into the deoxygenated blood. There are various types of ASD, which is known as Ostium Secundum, Ostium Primum, and sinus venosus. Here in the figure we can see this is the primary defect, which is shown in the center, which is secundum, ostium secundum. This is ostium primum, which is nearer to the valve. Here mitral valve we can see, or bicuspid valve we can see. And other types are of sinus venous, which are near either superior vena cava or inferior vena cava, or near the coronary sinus. So let's see each in detail. Ostium secundum. There is a defect in middle area of the septum, as we have seen in the figure. It is due to the failure of fusion of septum secundum to the septum primum to obliterate the foramen ovale. Foramen ovale was present in embryological life of child. In circulation of the heart in embryo, there is an opening which is required for circulation between right side and left side of the heart. But once it develops, there should not be opening between two atria. So this is the most common and simplest to correct. Next is ostium primum. The defect occurs low down in the septum and is sometimes associated with malformed mitral and tricuspid valves. It is due to defective formation of the interatrial septum as it fuses to endocardial cushion. The operation is more complicated because of proximity of the valves, coronary sinus, and atrioventricular node, which is AV node, which helps in conduction of the heart from SA node to AV node and from there to Purkinje fibers. Third type is sinus venous. This is a defect occurring high in the septum near to orifice of superior vena cava or low with near the inferior vena cava or coronary sinus. Let's see or understand the hemodynamics or pathophysiology of ASD. Usually in ASD, there is left to right shunt, and if the defect is large, it may function as a common atrium. So what happens? That every time left to right shunt leads to overloading of the right atrium, then followed by right ventricle and pulmonary trunk. So there will be enlargement of right atrium, right ventricle and pulmonary trunk. Gradually there is increase in pulmonary hypertension, which may lead to back pressure to the right ventricle, which creates right ventricular hypertrophy. There can be right ventricular failure too. Once a right ventricular hypertrophy develops, even some in a later cases, that happens that right side of the heart is having higher pressure than that of the left side of the heart. There may be chances of reversal of the shunt at that time, that is from right to left side, and at that cases may show signs of cyanosis because of deoxygenated blood gets into oxygenated blood mixture. So this is the hemodynamics of ASD. What are the symptoms along with it? If there is a secundum, ostium secundum kind of lesion, there may be asymptomatic or show mild exertional dyspnea as the blood flows from left to the right atrium, thus overloading the pulmonary system. So overloaded pulmonary system gives exertional dyspnea. In primum, defects may produce extreme dyspnea due to the left ventricular failure if mitral valve is also involved. These kind of patient are usually does not have normal growth. For these type of disease, the treatment is only a surgical option. Medical treatment can be given up to 1 or 2 years of the age as a palliative treatment for ventricular failure or any subacute bacterial endocarditis etc. We can give medical treatment. For surgery we require either median sternotomy or anterior right thoracotomy incision through fourth intercostal space. Here we can see either there is a median sternotomy or anterolateral thoracotomy done in a child through fourth intercostal space on the right side. Next is the treatment for ASD or surgical treatment for ASD is always with open cardiac surgery. So heart is entered through the right atrium and the secundum type is closed by direct suture. Here we can see on the left side they have taken a direct suture of the opening, and on right side they have attached a patch for closure. If there is a large opening, we can use a Dacron patch, as well as for premium and sinus venous type a Dacron patch is used. So the premium type is repaired by insertion of a Dacron patch. If the mitral valve is involved, it will be repaired first and then Dacron patch is attached. Great care is taken to avoid damage to the atrioventricular bundles which run near to the operation site in case of premium type. In sinus venous type is associated with anomalous drainage of the pulmonary veins from the right upper lobe into the right atrium. So the defect is repaired with a Dacron patch which redirects the venous drainage into the left atrium. Pre and post-operative physiotherapy treatment following surgery is same as that of a bypass, that is coronary artery bypass surgery, which we have already discussed in previous video tutorials. So please do watch them, which includes pre-operative physiotherapy assessment and management of any cardiac surgery patient, as well as post-operative assessment and management of cardiac surgery patient. Usually these kind of patients are being discharged after 10 days of surgery. Routine follow-up and general physiotherapy will be followed just like a bypass scheme. Here are the references. Thank you.